to, yes, we are going to record this. We're going to record the beginning for sure. And then when we get to questions, we'll decide if that should be recorded or not. And I'm going to pass this off to Jody, who's going to help moderate this morning. And Jody, do you want to just reintroduce yourself to folks?
Yes, I was
Thank
going
you.
to. So hi, I'm Jody Krastek. I'm the supervisor of the palliative care, pain and palliative care clinic here in Children's Hospitals and Clinics of Minnesota. And I'm really delighted to share Danelle Shu with you. Danelle has many gifts: mother, palliative care advocate, mentor, teacher, artist, a good friend, and many more. She's been a pediatric palliative care leader as a parent, both nationally and in our state. And she's really brought the voice of the family into these committees, including policy and education, in a really unique way. So I'm very excited to have her here. I want to give her as much time as possible. But as we listen to her, I urge you to think about those questions you always wanted to ask parents, and you felt like you couldn't for whatever reason. Danelle is very open. So when I told her I was going to do that, she said, "That's great. I love those kind of questions." So I'm going to hand it to you, Danelle.
Thank you, Jody. Welcome, everybody. I'm so glad to be in this shared space with you. I wanted to start by introducing you to my son, Levi. I'll share just a little bit of photos here. Levi, here we are, is a boy who was born with severe brain damage. You would know that as severe HIE. And the top two pictures are Levi in his first few days of life at the neonatal ICU. He was born full term. We did not expect this journey in our start of parenting. We were bringing the first child into our family and the first grandchild into both sides of our extended family. And then we found ourselves in the neonatal ICU. As you know, it's a very precarious, unexpected space. And we journeyed that moment by moment, hour by hour. Our initial prognosis for Levi was hours to days, and then to prepare for what comes next, without anyone ever saying he's probably going to die. All signs were pointed that way. So that was our first lesson in the experience of life with Levi. And then thankfully, his body did come off the cooling blanket, did come out of a compassionate extubation experience. His body could support his own breath. And by the end of the second week, we got what I call the golden gift of a palliative care consult. That consult changed our life forever. We met a palliative care team from another hospital. The hospital we were at didn't have their own home-based palliative care team, community-based. And so they met us in the NICU, and we started talking about what it might look like to go home. And by 3 weeks of age, that bottom left picture is Levi on his first day home. He needed a little bit of oxygen and a nasal gastric tube. And we went from being supported by an entire ICU staff to mom and dad are somehow going to run an ICU at home. But thanks to palliative care, we were able to learn how to do that step by step and season by season. As you can see, Levi, as children do in unexpected ways, he outlived his first prognosis and several after that. He lived old enough to be a big brother. His brother Leo, which you can see in the middle picture, and my husband Peter, and Levi and myself. This was our last big family picture. So Levi was 2.5 when Leo was born, and Leo was 4.5 when Levi died at the age of 7. The picture on the far right is Levi on his last birthday, just a couple months before he died. And thankfully, because of concurrent care, Levi had life-prolonging, life-sustaining support, which include all of his therapies, all of the things that help make life beautiful and wonderful for him. And on this birthday, he had palliative care, concurrent care, and hospice care, a part of his life. And you can see that we still made a birthday, even in hospice. I'll share just a little bit about myself. So really, thanks to Jody. Jody was our palliative care nurse. So it is you as clinicians who open the doors for families to become advocates. You're the ones who sit at the tables and say, where's the family at this decision-making table? Where's the family in this development of curriculum or this question about how we should improve best practice or research? So I want to encourage you that you are the ones who open the doors for families to come forward. And Jody was the one who said, hey, would you ever consider? And that's led to a whole lot of other things. So I've been able to advocate for families since 2004, and Levi was still alive at that time, and then continue advocacy as we journeyed through his life, his end of life. I took a break after his death and have returned not too long after that. One of the interesting spaces that I advocate is in and provide care for is in education. So at the University of Minnesota, we have a really beautiful project, end-of-life skills simulation, and I'm one of the faculty that's helped develop the programs as well as be a part of the actual workshop faculty. And then I also designed resources for supporting clinicians as well as families in navigating grief, bereavement, and resiliency. So that's a few things about me. I serve nationally and in our state of Minnesota. But I want to go back to this space where we can see each other. So I have a couple of things that I want to just touch base on. This is an article that I wrote while Levi was still alive, and I will share that article with you. So you don't need to take notes on the article. What I'd invite you to do is take notes on what questions rise up, or if there's certain experiences that you've had or experiences you wonder about that you might think, oh, applying that in my setting, I want to take that with me. Like, I want you to take something home from this that you can actually implement in where you are in your learning process as a clinician. So listen for that. Don't listen for the whole list. Listen for the thing that bubbles up, that resonates with where you are, what your role is, and what you realize, oh, I could add that to how I'm learning and how I'm engaging with families in the setting that you're in. Okay? So the first, I say it every time just because it's not obvious. A child is a whole person. In clinic settings, in hospital settings, in outpatient settings, in home-based settings, in specialty settings, in your role, very often you learn within a specific role or a specific aspect of a child. And it's important to know whatever role that is, whatever perspective or setting that you have, that that child is a whole person. Most of our healthcare is very siloed. Palliative care is one of the unique and special places where there's interprofessional collaboration, and you get to be in dialogue with many different perspectives about the child and about the family and care. And be reminded that that child is a whole person. They're a whole person in terms of three-dimensional body, mind, heart, soul, and spirit, but also social, emotional, who they are in their family, their education, their connections to community, their preferences and things that they like and don't like, just like all of us. So that's a place I like to start. Another thing I'd like to share is many times, and Levi was a child who you probably saw in these pictures, who didn't, because of his diagnosis with severe HIE, and like many kids who have neurological impairments, or maybe it's a genetic condition that has them where they are, many of them are nonverbal, or they have limited movement, or they appear as if they don't communicate or understand very well. And I want to remind and encourage you that our children do understand. We have a kind of way of being, and as parents, we do it too, where we talk over the child. And in palliative care, one of the things we really were guided and supported and encouraged in was to talk to Levi. So anytime you meet a child in clinic, outpatient, address the child directly. They're in the room. They're a part of the conversation. Address and engage them directly. And if you don't know how, ask the parent. Levi was deafblind. He had impairments in hearing and vision, different levels in both. And so his way of communicating had to involve touch. If you were to be an effective communicator with Levi, you needed to make physical contact with him in specific ways. And that's something you can ask parents about. And even if they say, well, just turn and talk to them, then you know, right? So each child is unique, and each child's methods of communication are unique, and be curious about that and learn to engage directly with the child and notice when you or the community having conversation is talking over the child. How do you engage the child in the conversation? And that also has to do with key decision-making points, whether they're big ones like surgery, or what seems like a small one, but a big one to a family, like, oh, we'll just go from scheduled feedings on a feeding pump to a continuous drip. That's actually a big decision for a family. Seems pretty minor, just settings on a pump, but that's not true. Engage the child. Ask the child what their perspective is. Ask them, engage them in decision making. And that includes, as you do in palliative care, observe the child's body. Learn the physical language of the child. What is the child's body telling you? That is one of the things that palliative care is very skilled at, and you can be skilled in that in your role and perspective. Whether you're a child life specialist, you're a social worker, a chaplain, not just the nurses and the physicians and the physician's assistants, everyone can be engaging with the child and asking, what does this child say about this? What is their input into this? And then how do we know what that child is communicating? Because they are present, they do understand, and they do have a voice in their own life and their own care. Another one is, like I mentioned already, little medical decisions and big ones affect the whole family. So ask about that as you're presenting options of especially medical decisions. Ask them, how would this affect you? It's not just about changing the setting on the feeding pump, but looking at the ripple effect and inviting that conversation, inviting the family to have a conversation about that as part of shared decision making. It's not just the nuts and bolts, but it's the ripple effect of how do these decisions, adjustments in care affect the family as a whole and affect the household. Because as Levi got older and he became a big brother, it wasn't just that a continuous feeding pump meant we had to completely change his physiotherapies and his occupational therapies and all the therapies we did, because now he's connected to a pump all the time. And it wasn't just oxygen, because oxygen has a nice long tail of a tube. The feeding pumps don't have quite so long. But then it also affects the family. How does that affect Leo as his brother? How does that affect how we eat as a family? Meal times is many times a family gathering space. So when a child's feeding, as the example, needs to be adjusted or is being considered to be adjusted, there's a ripple effect into what that impact is in the life of the family and how the household, how the family experiences daily life. I'm curious as a show of hands, and you can do this through the icons. How many of you are or anticipate in your practice going to be seeing families in a clinic setting specifically? I know there's lots of settings, so you can raise your hand or you can do the Zoom hand raise. Trying to check over. Okay, several of you. Awesome. So this was one, if most of you are not in that setting, I was going to skip over. One thing to know about families who have childs with special healthcare needs, medical complexities, and this includes families with children with cancer. It's not just kids like Levi. Is broadly speaking, it can take a half a day to a whole day's preparation to get to you at clinic. That moment when you see us in clinic, or that first administrative person at that front desk sees us, it likely has taken us a half to a whole day to get ourselves ready for that moment. So when we show up and there's a cancellation and nobody's communicated it, that's a problem. When we show up and providers are dismissive of the questions that we bring forward, that's a problem. When we show up and things don't run smoothly or people don't listen, that's a problem. And for a child who has medical complexities, that half a day to day preparation might also mean that their symptoms get exacerbated. We found that with Levi. I see that with other families, is the work it takes to get to clinic sometimes changes the where the child is. And they might have had a calm morning, no congestion, breathing is going good, heart rate is good, all the vitals are good. But by the time they get ready, get in the car, well, depending on the house, it might be they get into their wheelchair, which may or may not roll into the vehicle. So then you're getting them out of the wheelchair, into the car seat of some kind, all the way to clinic, that ride, however long or short it is, then getting out of that, whatever it is in the chair, in the car, and then getting into the wheelchair, and then getting all the way to clinic and waiting until they see you. That, as well as all the things that they've had to pack just in case X, Y, or Z happens, all takes time. So there's a massive effort that families go through to just be in clinic with you, and knowing that helps understand the level of stress or anxiety that parents might bring with them. So when you engage with parents and there's high levels of stress or anxiety, some of it might be because it's taken so much work just to get there. And some of it might be that they're finally able to be in clinic with you and ask questions or receive care in some ways. And they've been waiting and waiting and waiting for this. And as I'm in relationship with families whose kids are living now in this post-COVID space, I don't fully say post-pandemic, but post-COVID space, it's even more difficult to get to clinic and to get questions answered. And the stress levels are very high. And the capacity levels are low, and families are caring for their child with not enough help at home. And so parents are showing up in an exhausted state already. So knowing that, having compassion for that, and welcoming them in with a kind of hospitality that has some understanding makes a difference. We as parents know and understand that when a clinician welcomes us in and has some understanding for how much work it's taken to get to clinic, it makes a difference. A few other things I won't go into total detail. As palliative care minded people, care coordination is huge. I've talked about siloed separations. We need your help in care coordinating. We are experts in our child. You are experts in your field and your specialty. And maybe that means the specific diagnosis that our child has that we're coming to you for. And we can't see what you see in the ahead. So even though, like in Levi's example, in the NICU, the prognosis didn't turn out to be how it went, knowing the prognosis was still helpful. It was still helpful to have anticipatory guidance. That's part of the collaboration that we as parents need from you, is your anticipatory guidance of, this is some of the ways we've seen it go for kids who have a similar diagnosis or are experiencing similar challenges. In this space of a parent being an expert, you being an expert, and this collaboration, something that I'm hearing a lot of parents say right now, and especially the older the child gets, is the older my child gets, the less I'm believed. The less I'm believed. When I come in and say my child's having repeated GI issues, we've been doing all the scopes, we've been to ENT, we're back at GI, all the things, and saying it's something still wrong. I know this. I know my child. Something is wrong. I'm concerned it's pain. I'm concerned it's this or that. I'm hearing a lot of parents say, I'm just being dismissed. They're not being fully believed. People aren't stopping to really hear the concerns that I have about my child. And the fact that parents are saying, I can't put the pieces together. I need a provider to help me with the missing pieces and to be present with me in the uncertainty of it. That's a big one, being present. In terms of communication, it is absolutely important that you practice silence. That's a part of being present in the uncertainty of it. And practice it. I encourage you as clinicians, and this relates to the work that I do at the U of M with the end of life skills work, is I encourage you to actually have a personal practice of quiet and stillness, so that when you're in front of a family, you already have exercised that muscle of quiet and listening, and then you're comfortable waiting. Levi was a master in patience, and through his life, he taught us what I've come to articulate as wait until you're uncomfortable.
Mm.
Then count to 10 and wait again. See what happens in that space. And, you know, the mind wants to do things and you want to jump in and contribute, but sometimes the best way to be present is to give your attention of eyes and heart and body language and just wait and listen and see what comes in that space. What does the parent bring forth, or what changes in the child? Maybe that's where the child gets a chance to speak up. Wait until you're uncomfortable, count to 10, and wait again. And so in that, the other thing that's also really helpful for families to hear is, I don't know. I don't know what the answer is. I'm going to do what I can to bring the right people together to try and help find an answer, but right now, I don't know. That is better to hear than being dismissed. All right, that's a whole bunch of things. So I would like to shift this over to questions. So Jody, and do you want to start with this, or maybe people want to add questions in the chat? And I want to say first, like Jody said, I'm an open book. You can ask me any kind of questions. If I don't feel comfortable or something, I'll let you know. I have yet to come across that question. I just say it not to challenge anybody, but just to say I haven't experienced it yet. And also a question that, like Jody said, maybe you haven't been able to ask a parent, you know, in the safe, brave setting of having shared experience. You are clinicians, I am a parent, we have shared experience through children and palliative care, but there are questions that don't always get asked. So maybe it relates to something I've said and maybe it doesn't. That's welcome too. And maybe this is a point where we decide if we're recording questions. I think that was brought up earlier.
Hi, I'm Jennifer.
Hi,
I'm
Jennifer.
a neonatal nurse practitioner in a level 4 unit. So I don't see kids in the clinic, you know, but I guess my question is, especially early on, because I deal with a lot of HIE, is there anything you wish you would have done differently? Or even anything we could have done differently?
Yeah. I'm writing this down because I like to remember the questions. Are you asking that in the space of the neonatal space or in terms of Levi's life?
Mostly in the neonatal space. In the first, 3 weeks you were in the NICU. Yeah, that time period.
I think I would have taken more pictures. That's one of the things I would have done. I would have liked to have had the opportunity to engage in memory making. You know, sometimes that is brought in at that for sure dying end of life space. But that's also what got missed at the beginning, right? Naturally, you know, we birth our babies and we bring them home, and then the memory making starts, you know, photos or handprints, right? Those are things that could be offered in the birth neonatal space before death, whether the child dies or not. You know, many of our HIE kids do experience death in the neonatal space. But there wasn't any of that memory making as a way of bonding, so providing bonding experiences. And that's what I'm thinking of, not in the frame of we're concerned your child's going to die, more in the frame of we want to support bonding with you and your child, even as they are fragile. Because for him on the cooling blanket, you know, it was 3 days on and then good 3-4 days off. You know, it was a slow coming off. So our ability to touch and hold him was, you know, quite limited. So then what other ways could we bond with him? I had the opportunity of pumping. My husband didn't have a lot of opportunities. So that's also like, how do we think about that in terms of the men, the dads, the brothers, the siblings? What are those ways that we can invite bonding through creative memory making? Great question, Jen.
Great answer.
I have a question. I'm Robin. I'm a nurse who makes home visits with kids on Peds Palliative, and then also some on concurrent care. But I'm just wondering, I kind of struggle sometimes. A lot of my kids have a lot of ongoing symptoms, issues, ever-changing care plans in a way. And so
Mhm.
sometimes when I don't see them for a couple of weeks, I feel like I have to start kind of not from scratch, but trying to just get a real feel for where they're at. And I certainly don't want to burden the family. Sometimes I feel like it's a lot to go into all these details, but then sometimes that's also where I discover, oh, I don't think you're supposed to be giving budesonide 4 times. I mean, in my brain, I'm like, oh, they're not implementing the care plan, right? They just
Right.
missed the little
Yeah.
piece that's really important. And so I really struggle between getting in the weeds with them every time just to be able to kind of catch those things that, okay, they didn't know there's this resource out there. Let me help them with that
Mhm.
versus just letting them drive the conversation more. Do you have any I hope I'm making myself clear. I never feel
Yes.
like I say things very well. What did you appreciate from home visits from palliative care?
Those are great questions, and I resonate with both of that, right? How deep into the weeds do we get every time, especially if there's been a gap of being able to see the child. And then what did I appreciate about the home visits? We were fortunate. We had home visits almost through Levi's full 7 years. We had a gap of about a year and a half in there. Those home visits are golden. And I use that word specifically also. When you think of from the family perspective, there is no one who really sits down to talk about the full care plan with you. That I found was mostly the palliative care team and especially the home visits. You tend to talk about a little about what's going on with GI with that group and ENT with that group and pulmonology with that group. But nobody really sits down and lets that full comprehensive plan come to life. And as parents, we are navigating all the little nuances. We are the train station. All the trains are coming in from all the different directions. And we as parents, especially the parent that's holding the entire child's medical needs, right? There generally tends to be one parent who's holding everything. And that parent often doesn't have anyone to talk to that is really willing to get in the weeds with them. That actually is one of the gifts of the home visits is you do get in the weeds with us as parents. You do talk about the nuance and help us figure out, oh, these medications, they're bumping each other. Or did you know that, you have this nebulizer that's in your toolkit? And that was one for me is I had an aversion to nebs. I didn't really understand them. Jody knows it took a lot of education for me to really no, really, these are good things, right? And so it took a while for me to really get a handle on like which neb medication I would use and when and why. What's the difference between these 2 or 3 different options and become skillful at that set of resources in my toolkit. So that's a time for education. It's a time to like finally bring all the nuance out. And I found that some of the best visits not only talked about the nuance and let me like show the superhighway that was being built, all the exchange of trains in and out of the train station, but also was someone who would ask the questions about how is that impacting Levi's life? What about that matters most? Whether that's he's experiencing drops in his oxygen levels, like what is that impacting? It's not just the nuance of the nitty gritty, but get to the story of the experience inside why these things matter. Why is the parent have a concern about what seems to be a reflux issue, but it's really, they're reading it as a pain issue. Why is that a concern? What is the impact of that? It's not, again, there is a medical piece, but there is also social, emotional, other pieces to that. So getting to the story of that. I wish there were more home visits. I wish more of the team could come to the home, including the nurse, so that as chaplains, as child life, as social workers, you could get inside both the nitty gritty, but then that super highway of like what all's going on. The zoom up in the helicopter and the drop down into the weeds.
Thank you.
You're welcome.
And now what you were talking about fits in really nice with our PEDS module that we're doing actually about a care plan, how, with the child in the middle, and then you have all these spokes of the different people that you see: pulmonology, GI, neurology, school, waiver, all of that. And you're trying to kind of hold that all together.
Mhm. Yeah, that's a massive job that the parents have. And in particular, if there's one parent that's holding it more specifically. In our home, both of us held it, but I held all the details.
Now I'm wondering if this is a double question. So when you think back about one of your most challenging days, and then when you also think back on one of your good days, from a provider, nurse, social worker, chaplain, interdisciplinary team, when you think back on a day that was just not good, could you share some advice to this interdisciplinary group of people about something that might have made it better, or something that felt like it was missing that made it a hard day? And then when you think back on those days where you just thought, wow, like this is really hard and this was a really good day, and not just from the lens of being Levi's mom, but from like our professional roles and what we did or didn't do that sort of made those days. Because I so appreciate the idea that sometimes it is the small things and sometimes it's the big things. Like sometimes
Yeah.
we really could do better. And
Yeah.
and so what could you share with us sort of on both of those sides?
Yeah, one of the things I would share is that what makes the hard days easier is having a care plan.
Mhm.
That's, in fact, I have a statement here. I wanted to read it because it's in the article I'll send, but it stood out to me. And then let's see if I can find it. Making medical decisions without first having a care plan is risky for my child. When we have the gift of a goals of care plan, and I'm talking about that palliative care, what are your hopes, your fears, your wishes, what are your goals, right? And you start with that, you start with those pieces, and then you work your way towards creating a care plan that helps that family take their values of who they are and what kind of life they would like to give and have and enjoy with their child and with their family, and then help them translate that into medical decisions, which then becomes the plan, the framework. On the hardest days, we leaned into that plan really hard, and that made it easier. If we were having to get to the ER and knew that that was going to be an admit into the hospital because things were going so far awry, we had a framework for decision making. We had a framework for when and why we would go to the ER, and when and why we would pursue an admit. And I have been in relationship and know many families who have never had that plan. They've never had that conversation. In fact, one of my good friends, they have many children, and it wasn't until their last child that they had palliative care. And with the last child, when they finally got to have that series of conversations that led to the plan, then they like relaxed and they were like, oh, and then they could look back on the complex medical journeys of several of their children and say, wow, we would have made very different decisions all the way through each of those child's lives if we'd had a chance to do this first. So that, having that made the hard days much more doable, much more possible. Also because it meant my husband and I had had those conversations together in a calm, supported space with the team. We weren't in the high stress of, oh my gosh, we got to make a decision, or oh my gosh, there's been a fill in the blank, right? We weren't in that high stress, high emotional space. We were in the calm space, and we could make decisions and plans. As hard as it is to have those conversations, they prepare the way for the inevitable hard days to go better. Because if I was the one taking Levi to the ER, there was a whole set of decisions we'd already made that I didn't have to be calling him and interrupting him at work and stressing him out. I could just simply say, hey, we're on our way to the ER. You know, I'll be in touch with you. We're implementing the care plan heading to the ER. And he knew what that meant. He didn't have to get stressed about it. He didn't have to be like, oh, but we haven't had the conversation about.
Mhm.
So that, and then
And
what
Danelle,
made,
can I ask you
yeah.
one? So let's say you're on your way to the ED.
Mhm.
And you know, and your husband knows, like you're really settled, and then you meet me, and
Yeah.
I've never met you before.
Right.
And I say, you know, I do some good things. I say hello to Levi. I,
Mhm.
you know, ask you to tell me a little bit about, you know, what's going on. How do I, like, one of the things I'm thinking in my brain is that I would say something like, if I knew you, you know, based on what you've told us in the past, it sounds like we'll do these things. Did I get that right? And that's great if we have a relationship, but do you have any tricks about how we can tell you that we, like, how do we find out the care plan? Kind of going back to Robin's question a little bit, like, how do we, are there any ideas you have about how we can find that out without, like, how much do you have to say to us? How much do you want us to ask? Because if you know what you want and I don't know what you want, how do we, I think that's sometimes where we get, lost,
Yeah.
and
I
wondering
would
if you could
say
share.
that's a great question. I would say, and I'm going to speak from the lens of a parent who has a medically complex child,
Mhm.
right? This is not my younger child's situation. We're in a medical journey. We live this journey 24/7 every day. We're coming to the ED. I would like to be asked, not why are you here, but
Mhm.
what is it that concerns you most? What is it that we can help you with? Because ultimately there were things that, as much as we did at home, there were a lot of things we couldn't do, right?
Mhm.
I'd love to have a mobile ultrasound unit come to these kids' houses. Can you imagine how much? Anybody want a business idea? No. Seriously, there's so many times we went to the ED just for an ultrasound, right?
Mhm.
But it stirs up a big pot
Mhm.
because you're showing up the ED with a medically complex child.
Right.
So really engaging that parent in validating that they know their child, that they've brought them here for some really important reasons, and you'd like to understand what those reasons are and how you could be of help. So you're
Okay.
approaching it from that partnership,
Mhm.
and maybe bringing that out because there are some heightened issues or situations because they're showing up at the ED, right?
Mhm.
It
Right.
might be respiratory, it might be you know, that they're really just there for an ultrasound and clinic wasn't open, or they know they have to go to ED for that.
Mhm.
These parents are very smart, and
Right.
they don't try to use resources that they don't have to use.
Right. No one wants to come to the ED.
Yeah, especially, yeah. Yeah.
Okay,
No.
thank you. That
Is
helps.
that
So,
helpful?
mhm.
Thank you.
Now, there's a comment about how important child life is. I'm wondering, did child life work with Leo at
No,
all?
that
Did
was
you have?
one of the parts of palliative care we didn't actually access or have access to. That was part of it. And this is, I mean, I really appreciate this, Virginia, you saying this, because this is another thing I would say is really valuable to parents when it comes to the care coordination. It's not just about, it is about helping with the transit station experience, all the roads going in and out. But it's also about knowing the team and the people beyond the team well, so that you can speak to who child life is thoughtfully, and you can then do a really great job of connecting a family and child life together. You are connectors, and you knowing both sides well. Maybe you've just met the family, so you don't have much of an opportunity yet to know them well, but I hope that you know wide and deep all the other people, at least in your system, whatever system you're in, but maybe even a little beyond that, if you're able to refer outside of a hospital system or a clinic system. I know there's some boundaries to that. But at least know all, like, go have coffee with all the people. Sit down and have coffee with Child Life. Sit down, or a bunch of you have coffee together, and like really get to know, like, what do you each do? And how can I best connect a family to your role?
I have another question, and it has to do kind of with terminology and wording of things. And I feel so, I so respect these parents for their care of their kids. And, there's lots of words out there like good parent, good job. I mean, I don't know what was meaningful to you. So you guys have done so much, so it's kind of hard to know what words to use.
Robin, your audio, at least on my end, cut out a little bit. Did anyone else hear it that can fill it in, or can you go for round two, please? I hear it now.
Okay, I'm wondering what words, actual words, were felt honoring to you, felt supportive to you as a parent. It's hard to know what to say sometimes when we have a lot of respect for a parent, or want to acknowledge the work they're doing, yet we only see a tiny piece of it. So I'm just kind of curious what words meant a lot to you as a parent.
I'm going to tag team this with Jody, if you'll answer this with me. So for me, things that meant a lot to me, and I know you're looking for specific words, was observations of the love and the care that you see me doing with my child. That as the focus, the words don't tend to go awry. When you're focused on, wow, I can see how hard you're caring for Levi, or just being able to articulate what you're seeing, right? And it could be specific on, like, how you're giving him the medications through that G tube, giving them slow and kind. I can see the kindness and the care that you have for him, even in how you give him his medications through his G tube, or how you're communicating with him and letting him know, hey, this is what we're doing, and then giving the medications, and hey, that's what we did. I mean, like, each family is going to be different on how they're showing that love and care. So looking for that, and then just bringing that to words. Jody, can you add or
I think
expand that?
you said exactly. I think that's really important, is to, again, kind of adjust it to the family, but to use, we have this acronym NURSE in our course, but that respect statement, I can see you really love your child. I can see that. And many times when you see the person as they are, then the tears will come and say, oh yeah, nobody's kind of said that to me. I don't feel like a good parent, and they're working so hard, right? 24/7, and things don't always go great. And so to have that affirmation, to show that respect, like Vanel said, I think is touches parents individually.
Thank you.
And feel free to write a question in the chat if
Yeah.
that's easier
easier.
or doable. Like I said, Levi taught me patience, so I wait until I'm uncomfortable, and then I count to
then count
10,
to
and then
10.
I wait some more. So I'll be hanging out.
I have another, I don't even know if it's a question or how to phrase it exactly, but I've been kind of on both ends of the spectrum with being in the NICU with kids, obviously, and then personally, my dad passed away a year and a half ago, and between those two experiences, there are times in the medical field I feel like we do things because it's part of our process, it's part of our protocol, it's part of this is, you have this situation, this is how you respond to it. But sometimes that's not always what's best for the patient. And that's what I learned from my dad. And yet in the NICU, there's so many times that you just automatically are like, oh, do this, do this, do this. How do you, as a parent, I can imagine that's very frustrating because, you find out the next day or even, 3 weeks later, these things were done without you necessarily knowing that that's what was done. How could we be better at that?
That's a really interesting question, especially in the space of an ICU setting, because there are times when things have to happen quickly. I remember distinctly, and in the NICU that we were in, we had mother rooms, so we were literally in the NICU unit. It's a very special arrangement. And yet, when you come out of that private room, you're in the NICU. There's not a lot of space. But I remember distinctly that day when I went in and I was just going to go down the hall to see him and then pump, and he wasn't there. Like the whole thing was gone, the whole thing, right? And he was off for a test or a scan, something like that. And it just like shocked me, right? And it took me a while to really understand, like, no, that really actually needed to happen quickly. And a spot opened up. Like, it wasn't an emergency for him. It was more like a systems thing where the spot for whatever it was opened up and they just put him in that spot and off he went. So being upfront, and I mean, in that moment, it would have been helpful if someone had come to me and said, we're moving Levi. Would you like to, say a little, see you soon? So just that would have been helpful in that moment, because it wasn't about having a choice on if he was going to have that. We know he needed it. We just didn't expect it to be then. It just got moved up earlier in the day. So just communicating, right? And it takes time to communicate. And yet that is, and then the anticipatory guidance of that. Sometimes it might be, we're going to do this scan or this test, and it's going to happen sometime today, maybe later today, but we just want you to know it could happen at any point, and we might need to just up and move him and then bring him back. So if he's not here when you come, it's because he's off having the test. So just that anticipatory guidance goes a long way. Jody, would you add to that?
Yeah, I was actually going to ask you, Danelle, you chose not to put a G tube in Levi, and he had
Initially.
an NG tube,
Yeah.
initially NG tube
Yeah.
for a long time. And can you tell us a little bit about that? Were you offered it? How was that communication? Is that something?
Yeah,
that
so
we could
in
learn
the ICU, the neonatal ICU we were in, we were allowed to go home on an NG. That's how I would say it now, because there are neonatal ICUs where it's not allowed. If you're going to go home, you got to go home on a G tube. So I actually felt that it matched our values and our goals for Levi to not have that surgery at that time. He was 3 weeks old. He was 1 week or 2 weeks from extubation. He was very still fragile, even though, you look at that cute picture and it's like, oh, well, he looks, kind of robust for being a fragile kid. But for us, we would have really been in a hard place if we would have had to face surgery in order to go home. That, based on our goals of care, even what little we had figured out at that point, that's before we'd had the extended conversation and made an extensive plan, both the care plan and the emergency plan. That would have been a huge hurdle for us. So for our experience, it was a gift to go home on an NG tube. We were able to manage it, and I even learned eventually how to replace it on my own without a nurse present. It took some practice, but it was doable.
Good
You
job.
know, and we understood the risks, we understood the challenges. And the reason I learned how to change it is because we had a value that we wanted to travel. We wanted to take Levi beyond the house. And that meant if we wanted to go more than an hour's drive, because we figured if we were an hour out and the NG tube came out, then, you know, an hour back would be doable. But if you got to 2, 3, 4 hours drive, that felt like, well, what if he doesn't have a way to eat for that much long, right? That felt risky for him and that. So Levi actually had his NG tube almost till 4 years old.
Something like that.
Yeah, yeah. So from our experience, it's completely doable for families to manage that. Now, there were some factors for us that were a little unique, but overall, we learned how to care for it. We learned how to replace it. We learned how to manage it getting pulled out and, you know, all those risks. But families can learn a lot of things.
Amazing how much families can do. And I'm sure those of you who work with families were always kind of surprised that how amazing they can do all the things. And I realize we're getting really close to the end of our hour here, but wanted to give a chance if someone was like, oh, I kind of want to ask a question, but I'm not sure. So if anyone does have a burning question, let us know, or, you know, you can certainly let Kathy know and we can get hold of Danelle. But Danelle, your wisdom and your clarity is so very helpful to us. We have so much to learn from parents, and I think we continue to learn, and hopefully that would be our goal, to continue to learn. I think the importance of care plans, I think you spoke very clearly to that, to have those thoughtful conversations beforehand, which is possible for some families, and some families just can't go there.
Absolutely.
So, and we're right at 3. Kathy, anything we need to
No, I
add, or-
don't. Just thank you, Danelle, for sharing such important words, and for also giving us a chance to meet your family and Levi.
Yeah.
It's always nice to have
Yeah.
a sense of who he is and the role he played in your family. So thank you for your openness and honesty. And I think, yeah, just thank you. And it was an honor to have you join us. So, and there's lots of, you probably can see in the chat, there's
Yeah,
lots of
thank you.
thank yous there
Thank
as
you.
well. So,
And thank you everyone for taking time out of your busy day to
mhm.
come here. I know you're all working, and so you kind of squeeze it in, and hope you get some lunch.
That's right. That's us West Coast people that are still hungry for our lunches.